Good morning. I'm Michael Fehlings from the University of Toronto, and I'm very pleased to speak with you today on advances in future directions in the pathophysiology and management of degenerative cervical myelopathy. And I'll take the perspective of where have we been, where are we now, and where are we going. Right at the outset, I wish to acknowledge and thank the World Spinal Column Society and the WFNS Spine Committee for this invitation to speak to you today. I wish to acknowledge the moderators and the coordinator for their kind support and invitation. I have no commercial disclosures. I am the principal investigator, however, on a few trials and projects that I will be discussing today. I work at the University of Toronto, and Toronto is a beautiful city. And once the COVID restrictions have passed, I would welcome any of you to visit us in our city. And I wish to also acknowledge the tremendous team of people that work with me. What I'll be talking to you about is somewhat reminiscent of this famous Paul Gauguin painting. D'où venons-nous, que sommes-nous, où allons-nous? In the English translation, where do we come from, what are we, where are we going? And this is, in a sense, what I will reflect today. So here's the outline. I will talk about the concept of degenerative cervical myelopathy, including the pathobiology. I'll discuss surgical options and also the evidence that surgery is effective. I'll present guidelines. And importantly, I'll talk about knowledge gaps and future directions, and in two principal areas. So one is optimizing the management of mild degenerative cervical myelopathy, and present to you the potential for a personalized medicine approach, and perhaps using microstructural MRI as an imaging biomarker. And I'll talk about optimizing neurological outcomes, and I'll present to you hot off the press the results of the CSM Protect study, which will be coming out in publication in the near future. There are three learning objectives. One is to define the concept of DCM. Secondly is to articulate the current guidelines for the management of DCM. And thirdly is to be aware of the key knowledge gaps in our understanding of DCM. We coined the term degenerative cervical myelopathy a few years ago in an effort to try to unify a variety of diagnoses that encompass the conditions resulting in benign, non-neoplastic, non-traumatic pathologies, including CSM, OPLL, and other conditions. There are three critical factors involved in the pathophysiology of DCM. There are static factors which result in compression and ongoing ischemia. There are dynamic factors related to dynamic compression, axial tension on the neural elements, and this is related to instability, which is there, and the alignment. And then there are biomolecular factors. So DCM is a form of spinal cord injury, a non-traumatic form of spinal cord injury. And there are many factors involved, but inflammation, ischemia, and excitotoxicity are key factors. One of the take-home messages for you is to use the modified Japanese Orthopedic Association scale to classify degenerative cervical myelopathy into mild, moderate, and severe. And there are outcomes related to motor dysfunction in the upper and lower extremities, sensory dysfunction, and sphincter dysfunction. Now also, there's a knowledge gap here because while the MGOA is probably the best outcome measure we currently have, there are limitations, and in particular, it's rather insensitive to the detection of change in the mild realm. We know very little about the genetics of degenerative cervical myelopathy, and this represents an opportunity for the future as we consider a personalized medicine approach. We recognize that there are certain congenital conditions, including Klippel-Feil syndrome, that predispose individuals to DCM. There have been some genealogical clustering studies which have shown familial tendencies for the transmission of degenerative cervical myelopathy. And it's also recognized that OPLL has a higher incidence amongst Asian, and there are linkages to certain genes, including the NPPS gene. But this is certainly an area of opportunity for the future. I'll present to you the concept that degenerative cervical myelopathy is a form of non-traumatic spinal cord injury. And here, the predominant type of cell death is not necrotic, but is genetically programmed cell death or apoptosis. Using animal models of this condition, including the twi mouse that develops spontaneous ossification of ligamentum flavum at C1, C2 of the spastic quadriparesis, and in combination with human postmortem pathology data, we had this report in Brain a few years ago, and we showed evidence that neural cells undergo a programmed cell death, and this is related to activation of a death receptor called the fast death receptor. And from this emerges some of the initial concepts around the pathophysiology of degenerative cervical myelopathy. Chronic compression leads to ischemia. This can activate death receptors and lead to programmed cell death. And in addition, there's disruption of the blood-spinal cord barrier, which leads to inflammation triggered by microglia as well as T cells. Now, surgery is the mainstay of the management for patients with moderate and severe DCM. And we have excellent surgical options, and this is an area of ongoing development. So I just thought I would share with you a few cases and a few perspectives that I have. So this is a patient who has a kyphotic deformity with at disc level, and the deformity is partially reducible. And in my hands, I really like the multi-level anterior cervical discectomy infusion procedure. And this is usually done as a standalone procedure. And this had an excellent outcome in this patient. And on occasion, one can combine this with a corpectomy in this so-called hybrid type of an option. And the addition of the midpoint of fixation provides excellent biomechanical stability. You'll see again that this is done as a standalone procedure. There are also excellent posterior approaches. I tend to favor the posterior laminectomy infusion approaches, particularly with patients with cervical spondylosis, multi-level pathology with relative maintenance of the cervical lordosis. But laminoplasty is also an excellent option, particularly in the setting of OPLL with a straight or lordotic cervical spine. And on occasion, combined anterior and posterior approaches are indicated, especially in situations such as this one, where there's a fixed kyphosis and where multi-level anterior decompression reconstruction is required. And then I like to combine this with a posterior decompression and reconstruction of the posterior tension band. Now, DCM has a tremendous impact on the individual, on society, and on caregivers. And truthfully, we lack granular data. But it's clear that there are significant economic productivity losses and costs related to disability and impairment. And the impact on the patient are tremendous. We can infer the costs of caring for patients with cervical spinal cord injury from the traumatic spinal cord injury literature. And if you look to the right of this a graph, and you consider patients who are 50 years of age, who have preservation of neurological function, we see that the costs can run into the hundreds of thousands, if not millions of dollars. So this is an expensive condition. Now, we've also evolved in terms of our concepts in the treatment of DCM. And currently, we really lack data on any non-operative algorithms. And this does represent a knowledge gap. It's also clear that many patients will decline without a treatment. And recent evidence has shown the effectiveness of surgical intervention. This was one such study which I led a few years ago through the North American AO group. And here we found in a prospective series of patients significant improvements on the MGOA score, reductions in impairment as shown by reductions in neck disability index, and dramatic improvements in the SF-36 physical and mental component scores. And this was a couple of years later replicated by our group at the international level, showing identical results. So very robust improvements in outcomes with surgical intervention. And so recent evidence has resulted in a paradigm shift. When I was a resident, we were taught that surgery was a last resort, and at best we could offer patients the idea that it would halt neurological deterioration. We now recognize that surgery is not a last resort and should be indicated at a much earlier stage in the course of the patient's illness, and generally will result in improvement in neurological function. Now, there remained a knowledge gap, and this is the fact that surgery is expensive. So is a surgery for DCM cost effective? So in an effort to fill this knowledge gap, we undertook the following health economics analysis, and I wish to acknowledge Chris Whittew, who at that time was a master's student in our group. So we took the data from the North American and international AO studies, and then we used accurate microcosting data, which are available in Ontario, to define the costs of the surgery. And the perspective here was that from the healthcare payer. To assess the outcomes, we measured health utilities using the SF6D, and this did show very substantial improvements in quality of life with surgical intervention. From this, we then calculated what's called an incremental cost utility ratio, or ICER, where you're looking at the cost of surgery versus the cost of non-operative management, and then looking at the relative utilities of surgery versus non-operative management. And then we use the WHO definition of what constitutes a cost-effective intervention. And this is the cost to gain one quality of adjusted life year, or an ICER, which is less than the value of the gross domestic product per capita. And in Canada, this is $54,000 Canadian. We used in a Markov transition state model to model all the different forms of treatment that could be applied to a patient with DCM. But basically, what this shows is what happens when we model surgical intervention versus non-operative intervention. How many patients improve, how many patients deteriorate, and then what are the relative costs of this. And then based on this, we found that surgery was highly cost-effective with an average ICER of less than $12,000 per quality adjusted life year. And when we modeled this using a Monte Carlo sensitivity analysis, we found that 98% of the time, surgery was the preferred treatment and was highly cost effective. And this work received the Outstanding Paper Award from the North American Spine Society. And again, I wish to acknowledge Chris Whittew, who did his graduate work at University of Chicago on this project. Given this background, we felt that it was time to initiate a guidelines process for the management of DCM. And this was undertaken through the support of AO Spine, the Cervical Spine Research Society, and our University of Toronto Spine program. To undertake this, we use what's called the GRADE process, and this is a two-step process. The first is to have high-quality systematic reviews, and then one has a multidisciplinary guideline development group. And this is one of the forest plots from the systematic reviews, and this is shown in the box in red on the right. And what this shows is that the mean effectiveness of surgical intervention is consistently to the right of the zero effectiveness line, meaning that surgery is highly effective at short-term 6 to 12 months and at longer-term follow-up. We then put together a multidisciplinary guidelines development group, which included a number of professional disciplines as well as individuals with a life experience with this condition. And this illustrates the GRADE process, where you take the best available evidence, you look at the clinical acceptability, consider patient values, look at benefits versus harms, and costs. And from this, we came up with the following recommendations. So for moderate and severe DCM, the recommendations are very clear that surgery is recommended. For mild DCM, things become somewhat more gray, and depending on the patient and physician preference, one might recommend surgery or perhaps a trial of structured non-operative treatment. And then if the patient fails to improve or deteriorates, surgery can be considered as the preferred option. Now, we recognize that patients have varied outcomes as well, and we've tried to get a handle on this in the development of clinical prediction models. And this was one such effort that our group published, and I want to acknowledge Lindsay Tetro, who obtained her PhD in our group using this, this work. So the key factors that we found that predicted outcomes for cervical myelopathy included age, the duration of symptoms, the presence of psychiatric comorbidities, in particular depression and bipolar disorder, whether patients smoke, the baseline level of impairment as assessed by the MGOA, and in addition, the extent of disability as modeled by the presence of an impaired gait. Now, there remain many knowledge gaps, and this will define the future directions. We do need to optimize the management of mild degenerative cervical myelopathy. We need a better understanding of the natural history. We need improved biomarkers. We need to evolve to a personalized medicine approach, perhaps using genetics. And also microstructural MRI could be a useful imaging biomarker. And I'll show you some evidence around this. We also need to optimize neurological outcomes. And here there's an opportunity for the translation of some of the basic science discoveries in regenerative medicine to the clinic. And I will briefly present to you the first randomized controlled trial of a potential neuroprotective drug in the setting of DCM, namely the sodium channel blocker, riluzole. This is a work from two former PhD students in my group, Alan Martin and David Cadot, and this was in conjunction with our wonderful MRI physicist, Julien Cohen-Haddad at the University of Montreal. And essentially, what we would present to you is that there are a variety of tools that can be used at a practical level in the MRI suite to help define the structural integrity of the spinal cord. One could look at T2 weighted, T2 star weighted imaging to assess atrophy and compression, magnetization transfer ratio to look at demyelination, DTI and fractional anisotropy to assess axonal injury. And in particular, I want to leave you with the idea of using the T2 star weighted imaging, looking at the white matter to gray matter ratio as a surrogate marker of the severity of injury and potentially a predictor for patients' outcomes. I again wish to acknowledge Julien Cohen-Haddad and would invite you to look at the spinal cord toolbox that Julien has made freely available. So this is some of Alan's PhD work, and Alan found evidence that T2 star weighted white matter to gray matter signal intensity ratio was a very helpful biomarker for non-traumatic spinal cord injury or degenerative cervical myelopathy. And these were some representative images from his work, and I would invite any of you to use these algorithms, and please contact me if you would like some further information on this. I now wish to transition toward a brief presentation on the outcomes of the CSM Protect randomized controlled trial. And this is looking at the repurposing of a drug called riluzole, which is a sodium glutamate antagonist. It's an FDA-approved medication used to attenuate nerve cell degeneration in ALS. And we're using this in a repurposing fashion to see the effects in degenerative cervical myelopathy. So why is this important? Well, we recognize that while most patients do improve with surgery, the improvement is imperfect. Most patients do have residual neurological impairment, and not everyone does well. So if we look at this graph here on the right, we see that most patients improve, but the extent of improvement will vary. Some patients here in green do not improve, and a small number of patients continue to decline. And this pie chart on the left shows that there is a low but definite rate of perioperative neurological complications. And in these basic science studies, our group showed that riluzole blocks perioperative ischemia-reperfusion injury. And this is probably one of the key factors related to the development of delayed C5 palsy. And in addition, riluzole attenuates neuropathic pain and enhances functional recovery in animal models of DCM. So given this, we designed the following randomized controlled trial. The protocol was published a number of years ago in Spine, is also on clinicaltrials.gov. This was a multi-center placebo-controlled double-blind randomized trial in 16 sites across North America in 300 patients, and patients were randomized to receive riluzole or placebo 2 weeks prior to surgery and then 4 weeks after the surgery. The main outcome measure was a change in the MGOA score at 6 months, which in hindsight may have not been the best outcome measure to use, but that's the one we decided upon. And we had a variety of secondary outcome measures, importantly looking at pain. So 290 patients ultimately underwent a surgery, mean age of 58 years, and 90% follow-up was achieved. You can't read this table, but we looked at a whole variety of baseline characteristics, and for the most part, the groups were well matched. Complication rates overall were low, and riluzole was very safe and well tolerated. So here's the impact on the MGOA. The first thing to point out was that we did not see a difference between riluzole and placebo on this outcome measure. What we did see, and what we validated again, was that there were very large improvements in the MGOA score with surgery. My hypothesis here is that the MGOA may lack the sensitivity to detect a change in neurological function, and that better outcome measures are required. However, on the pre-planned secondary analyses, including the VAS scores for neck and arm pain, we did see a beneficial effect favoring riluzole, suggesting that riluzole may attenuate neuropathic pain in these individuals. And this was actually translated to an improvement in the SF-36 physical function scores, and was also associated with subtle improvements in the Asian motor scores, largely reflecting hand intrinsic improvements. So what we found was that a 6-week perioperative course of riluzole as an adjunct to surgical decompression did not have a significant benefit on the primary outcome, namely the MGOA, but did appear to have very promising effects on 3 predetermined secondary outcomes, and importantly, including pain. So I think that this is potentially interesting work, and I would encourage people to explore the use of riluzole in their own practices. And some of the questions that emerge are, would a longer duration of treatment have been beneficial? We use 6 weeks. Would 3 months or 6 months have been more beneficial? And do we need more sensitive outcome measures? For example, looking at hand function, better outcome measures to look at disability impairment and pain. So in closing, here are the take-home messages. Degenerative cervical myelopathy is the commonest cause of spinal cord impairment in the world. Surgical treatment of DCM is safe, improves neurological function, quality of life, and is cost-effective. And in the future, we need to increase the awareness of the DCM, and I wish to have a shout out for the AO Spine Recode project, being led by one of our former fellows, Mark Cotter, who's now on faculty at Cambridge University, and his student, Ben Davies. We need to optimize the management for patients with mild DCM, and there's an opportunity to develop imaging, serological, and genetic biomarkers. And finally, we have a tremendous opportunity to translate the wealth of basic science work related to neuroprotection and neuroregeneration, and try to see if we can use this to enhance the outcome of our patients with degenerative cervical myelopathy. And on that note, I'd like to close. Thank you very much for the invitation to speak, and I'm happy to address any questions in the discussion period.